on the left. This is the AIDS Education Training Center Lunch and Learn series, the edition. It's my privilege to present to you my good friend, Dr. Patel. She's a board-certified physician and an assistant professor in the Department of Internal Medicine. She's the Associate Director of Global Health Education at UTMB and co-coordinator of Global Health Interprofessional Core Course. She received her medical doctorate from UTMB and then went on to do her training at Brown. She's accredited by the American Academy of HIV as an HIV specialist. She's a master's in human rights from London School of Economics, and she attends general medicine wards, and she sees HIV patients here in Galveston and UTMB. So, Dr. Patel, thank you so much for coming and joining us.
Okay, great. Thank you so much. It's actually really nice to be here again. I think it's been maybe a year since I've been here, and I see some very familiar faces. So thanks again for inviting me today to talk about something that I'm very passionate about. Today, what I'd like to do is spend some time talking about non-communicable diseases in the setting of HIV and bone disease. Look at what the impact of HIV and particularly the antiretroviral therapy we use to treat it has on bone disease. You know, it used to be that we were really just worried about opportunistic infections with HIV-infected individuals, and now Pandora's box is open, and now that individuals are living longer and longer, we're noticing that they're actually at considerable risk for some of these other non-communicable diseases as well. And to help you guys try to identify which patients are at highest risk and how we should go about approaching them. You know, this is a very, I would say, new emphasis in HIV care. So a lot of what I'm going to show you today, it's all going to be an evolution. So this is with the best evidence and the guidance we have today, what I'm sharing with you, but it's likely to change year to year. So kind of be on the lookout for that. And also, so when we do identify that an HIV-infected individual has bone disease, what do we do about it? How do we manage the bone disease? Is there anything we need to do with their antiretroviral therapy? So those are some things that we're going to discuss today. But first, I want to take a step back and look at the snapshot of HIV in this country. You know, we've come a very long way from the days of the 80s, 90s, where HIV was among the leading cause of mortality among young adults. You know, now we have what we call a mature pandemic. And you can see here that in terms of prevalence, so the number of people living with HIV in this country, we sometimes think of it as a bi-coastal thing. You know, we think of California, we think of New York, but actually there's considerable prevalence just in the South. And Texas is right smack dab in the middle of that. When we look at what has happened with our HIV-infected individuals in Texas, this is what we see. This is slightly older data, but the trends are still continuing. You can see here the blue line, which is the number of new HIV cases. So it kind of peaked in the late 90s, and it has been relatively stable over the past 10 to 15 years. The green line here is actually deaths among patients with HIV, and it peaked in the mid-90s, precipitously declined with antiretroviral therapy, and has been relatively stable. So this is death from any causes, so it's not going to be zero, but it's as low as it's been. I want to draw your attention here to this red line. So this is HIV prevalence, the number of individuals living with HIV in Texas. And you'll see that, you know, as we get people on antiretroviral therapy and they're living longer and longer, you're going to encounter these patients in some way or the other, whether it's the inpatient setting, the outpatient setting, specialty setting, and as we're learning more about the long-term implications of HIV and antiretroviral therapy, we all need to be aware of some of these things. So as our patients are living longer and longer, they're also aging along with the rest of us. And it's estimated that by 2020, about 70% of the population in the United States that's living with HIV is going to be 50 years and older. And I hate to break this to anybody, but in HIV literature, 50 is called the older adult. I didn't make that up. I promise. I did not make that up. So not only are these individuals kind of really hit with this double whammy of the HIV plus aging, it's actually a triple whammy, because if we look at data of HIV infected versus uninfected individuals, what you see is that for every single age strata, HIV infected individuals have higher rates of comorbidities. So it's not just aging and HIV, but it's all that non-communicable diseases that we suffer from too. The heart disease, liver disease, kidney disease, all of those. And that's really what's emerged as a topic of a lot of scientific investigation now, is how does having HIV or being on these medications over the period of a lifetime impact the same diseases that the rest of the population is at risk for. So we're really moving into a different era of the HIV pandemic. So we've moved from the early days where we're really focusing on treating opportunistic infections, where people are coming in very, very sick and there wasn't as much to offer them, to the mid-90s, early 2000s, where we really were trying to get as many individuals that were HIV infected on treatment as possible. And now we're reaching a maturity where, yes, we're managing HIV disease, but also the comorbidities associated with it and with aging in general. So this is where primary care, for those of you that are in specialty care, where that team approach really helps. So now on to our topic of HIV and bone disease. This is what happens normally in the general population. So we know that men and women kind of mid-30s have a peak in their bone mineral density, and then it declines. With men, it declines slowly, and with women, there's more of a precipitous decline, especially when they get to menopause, because estrogen is usually protective with bone. So when we start to lose that, that's when these other issues come up. This is a great video I wanted to show you guys. So there, pull out the tray. Oh, I see the tray here. Okay. So this is a really good video just showing what happens with bone remodeling in general. Let's see. Okay.
The skeleton changes across the human lifespan. This is characterized predominantly by bone formation and growth throughout childhood, followed by a gradual loss of bone density that begins in early adulthood that can accelerate significantly in older adults. The density of bone is modulated by a group of cells including osteoclasts, which are multinucleated cells that resorb bone, and osteoblasts, which refill the resorption cavities created by osteoclasts. Osteoclasts anchor themselves to the surface of bone. This creates a microenvironment underneath the cell, which is referred to as the sealed zone. Within this zone, the osteoclasts create an acidic environment that dissolves the bone's mineral content. Once the mineral content of the bone has been dissolved, enzymes released from osteoclasts remove the remaining collagenous bone matrix to complete the process of resorption. Following resorption, osteoblasts move into the resorption space and start to produce and deposit organic matrix called osteoid. Osteoid, a substance made predominantly of collagen, forms a scaffold in which minerals including calcium and phosphate begin to crystallize. Some active osteoblasts become trapped within the matrix they secrete and thereby become osteocytes. Other osteoblasts will undergo apoptosis or will revert back to lining cells which cover the surface of bone. This cycle of bone resorption and formation is referred to as remodeling. There is also a process where bone formation by osteoblasts occur without prior bone resorption by osteoclasts. This results in an increase in bone mass and is referred to as bone modeling. Bone modeling promotes the growth of bones and is important for maintaining bone strength. Remodeling also plays an important role during bone growth by optimizing the growing structure. After the age of 30, most people experience a gradual loss in bone mass due to a relative decrease in the activity of osteoblasts compared with osteoclasts. However, there are many factors that impact the process of bone remodeling and influence the degree of bone loss we experience as we age. For example, medications such as glucocorticoids, which can promote osteoclast activity and also reduce bone formation. Proper nutrition and physical activity can help strengthen bone. It is also believed that osteocytes form a complex network in bone that can sense any increased workload on the bone and respond by triggering the differentiation and activity of osteoblasts to increase bone density. Conversely, when bone experiences reduced loading conditions, such as during long-term bed rest, resorption and remodeling increase to eliminate underloaded bone. Loss of bone mass reduces its strength and increases the risk of fracture. This highlights the importance of staying active, maintaining good nutrition throughout life, and being aware of personal risk factors associated with low bone density.
Okay, so I love that video because that's going on in our body all the time. You know, it's estimated that a baby will completely break down and reform its entire skeleton in the first year of life. And then after that, we do that about 10% a year. So, you know, the cells that we're really concerned about here are these osteoclasts. These are the ones that break down bone. And then the osteoblasts, these are the ones that build it up. And normally there is a balance. You know, there's a balance. The osteoclasts come in, they break it down. The osteoblasts go in, they build it back up. And what happens in osteoporosis is that this balance is lost. You have more of these cells breaking it down and not enough of these cells that are building it back up. So that's what's underlying osteoporosis. And initially, you can have mild osteoporosis where you can see these spaces here where the bone is getting more porous because more of it is being broken down than being built up. In severe cases, you can actually get a situation where more of it has broken down than is actually built in there. And, you know, our textbook definition of osteoporosis is this. A disease that's characterized by low bone mass and deterioration of the bone tissue, leading to increased bone fragility. But the reason we care about that is because it leads to increased risk of fracture. So in terms of diagnosing osteoporosis, there are a couple of things that are definitely giveaways. One is a history of a fragility or low impact fracture. So what this means is if you're standing and you fall or get pushed over, you shouldn't fracture anything. Falling from a standing position or less shouldn't be enough to cause a fracture. So if you see somebody that comes in and they have a fracture based on minimal trauma, then that's a trigger that, okay, there's something going on with the bones that's enabling this to happen. So they probably have osteoporosis. And we see this a lot with vertebral fractures. Sometimes the vertebral fractures can be so severe that the patient's actually losing height. And they're telling you that, you know, I used to be 5'8" and now I'm 5'4". Okay, it's not that severe, but you know what I mean. So vertebral fractures, Colles fractures of the wrist are another one that's common for this. And then the neck of the femur are kind of typical places. We also typically diagnose osteoporosis based on the DEXA scans. Has anybody here had a DEXA scan done? Okay, so what was that experience like for you? No problem. You just you get on the table, you lay down. It's mainly using enhanced x-rays. So instead of just doing x-rays on one part, which is how we normally do, you have two beams that are converging on the same point. And the difference between those beams is what calculates your bone mineral density. So this isn't anything painful like a mammogram. It's pretty benign. A T-score of -2.5 at certain places or below at the hip, the femoral leg, or the lumbar spine diagnoses osteoporosis. So sometimes you'll see T-scores and Z-scores, and it gets really confusing. The Z-score is what is your bone mineral density compared to somebody else that is age matched and sex matched for you. T-score is how does it compare to a healthy 30-year-old same-sex person. And what we really use to diagnose osteoporosis is more the T-score. We don't really use the Z-score except in certain conditions. So T-score less than 2.5 or below really diagnoses osteoporosis. There's also a condition that's a precursor to osteoporosis, which is osteopenia here. And this is where, you have decreased bone mineral density, -1 to -2.5, but it's not severe enough to be called osteoporosis. We still want to keep an eye on these people because they're obviously at greater risk for developing osteoporosis. So what is the link between HIV infection and low bone mineral density? So again, this is an evolving body of literature. We know that there's something about HIV itself because it is a pro-inflammatory condition, and there are also cytokines that are involved in bone disease that are affected by HIV as well. So we know that there is a theoretical association. We haven't quite been able to figure out what exactly that pathway looks like, what exactly that association is. But we know that our HIV-infected individuals have lower bone mineral density than the general population. And they also are 3 times higher in HIV-positive individuals than HIV-negative. So we know that our patients tend to have lower bone mineral density compared to the general population. And this isn't just older HIV-infected individuals that we think of. It's also younger as well. So there's something about just having HIV that impacts the bone. But we also know that our HIV-infected individuals also have other comorbidities that increase their risk for bone disease as well. So these are vitamin D deficiency, with our men, hypogonadism. For some of our patients that have been on treatment for a very long time, since the late 80s, 90s, lipoatrophy, central fat accumulation, some of the side effects of some of our medications as well. We also know that our HIV-infected individuals just happen to have higher rates of traditional risk factors for low bone mineral density. So these are things like smoking. We tend to have a higher percentage of smokers than non-HIV population, poor nutrition, lower bone body mass index. So this is the only condition where having some weight on you is protective, which is great. Higher rates of alcohol use, and we talked a little bit about vitamin D. There's also a link between the medications that we give and the risk for low bone mineral density as well. So there are studies that were looking at bone mineral density before and after an individual had been started on antiretroviral therapy. And this is all kinds, not just the bad kinds that we think about. And they noticed a reduction of 2 to 6% of bone mineral density in the first 2 years of being started on pretty much any regimen. And this reduction might seem a little modest, but it correlates to the first year of menopause, the reduction we see in bone mineral density during that period of time. After this initial decrease, it does tend to stabilize, but we know that there's something associated with those medications. There are a couple of meds that I think we're mainly familiar with being associated, and this is tenofovir. We know that that's associated with decreased bone mineral density. That's been studied very well through multiple different mechanisms. And some studies also show efavirenz and protease inhibitors also affecting bone mineral density through their effects on vitamin D metabolism. So our risk for osteoporosis among these patients is not just the HIV and the pro-inflammatory state and not just the ART that they're using and not just the traditional risk factors they have, but it's really all this stuff together. So that's why it's hard to tease out just, the contribution of one individual thing. So if you're at all confused about the screening guidelines for osteoporosis in our HIV-infected individuals, you're not alone because there's no consensus. We have multiple different guidelines from different foundations and associations, and they all say slightly different things. So I'm hoping that at some point in the near future, everybody will talk to each other and we'll get some consensus. But right now, there are really groups putting out their individual guidelines. So we have National Osteoporosis Foundation, the HIV folks in Europe, our folks here, and they have slightly different recommendations. So because of this, in 2015, a group of clinicians and scientists came together from 34 specialties, 16 different countries, to try to provide some evidence-based guidance for the following questions. So one is, who is at risk for these fractures? Who do we really need to be looking out for? What are the ideal screening, workup, monitoring strategies? And how should we manage their ART in this setting? So what I'm going to present to you in the next 2 slides, which are going to be a little busy, is a snapshot of the guidance that they were able to provide, which is really the only consensus guidance that we have at this time. So let's take it from the top here. So if somebody has a history of a fragility fracture, they've been on steroid use, which is equivalent to 5 milligrams of prednisone for at least 3 months or more, and they're at high risk of falls at any age, so you don't even have to look at their age, we immediately want to do a DEXA scan and measure their bone mineral density. If they don't have any of those risk factors, so they have no risk factors, and they're younger than 40, because their bone mineral density is likely already to be high, we don't really need to do anything. If they're in the magical 40 to 50 year period, this is when we're going to try to calculate what their FRAX score is. This is the fracture assessment risk tool. And this is what the FRAX looks like. You can get this online. There's also, as there is for everything, an app for it so that you can put on your phone. And what you're going to put into this are characteristics of your patients. So what's their height, what's their weight, what's their age, their sex, and do they have some of these other things? Have they had a fracture in the past? Do they smoke? Are they on chronic steroids? Do they have certain conditions like rheumatoid arthritis? Do they have secondary osteoporosis? We'll talk about some of the conditions that can lead to a secondary osteoporosis. Now for this, there's still a lot of debate. About half of experts will say, go ahead and click this yes button for your HIV-infected individuals because they feel like it is a secondary cause for osteoporosis, and half of them will say, don't do that. So they also ask about alcohol use, and then it spits out a number. And this is the percent that your patient will have a major fracture or a hip fracture within the next 10 years. And this is the calculation tool that we're going to use. I do want to note that we use this because it's all that we have, but it hasn't actually been validated in HIV-infected individuals. Even though we use it, they use it in studies, but it hasn't really been validated. How do we go back? Here we go. So we're going to do this FRAX calculation. If their score is less than 10, they're in this low category, in which case we don't do screening. Again, we don't need to do screening. All we need to do is ensure that they're taking calcium, vitamin D, give them lifestyle advice, and then recheck it in a couple of years. If they fall in this moderate category, which is a FRAX score of over 10%, then we're going to get a DEXA on these patients. If they're high, we're going to get a DEXA. We're also going to exclude secondary causes of osteoporosis as well. And when we get the DEXA, we're going to look for that magic T-score, which shows that they have osteoporosis. After that, we're going to exclude secondary causes, and these patients are going to get treated. They're going to get treated with our first-line bisphosphonate therapy, and we're going to do the same calcium vitamin D guidance as we do for everybody else. For the patients that have osteopenia, but they don't quite meet criteria for osteoporosis, we're going to go ahead and just make sure they're taking enough calcium, vitamin D, and we're going to repeat a DEXA. If it's advanced osteoporosis, we're going to repeat in 1 to 2 years. If it's mild or moderate, we're going to repeat it in 5 years. Okay, so this is how we use risk assessment, their age, and their FRAX calculator to be able to stratify patients. In terms of monitoring them, there's also, surprise, no consensus on appropriate monitoring, but what they recommend is for these low-risk patients to do a FRAX every couple of years. Osteopenia, we're going to do 1 to 5 years. And osteoporosis, if they're started on therapy, we're going to repeat a DEXA in 2 years. And then we're going to reassess the indication to continue that bisphosphonate in about 3 to 5 years. So these are some of the secondary causes of osteoporosis. And really, it spans a spectrum of different types of diseases. You have GI diseases here. You have hematologic diseases, pulmonary things. I wasn't even aware that emphysema could cause secondary osteoporosis. The things that are bolded here are the conditions that are more prevalent among our HIV-infected individuals. And I'd like to kind of bring your attention to a couple of things. One is our patients tend to undergo menopause earlier. And you may have noticed this among your female HIV-infected patients that, you know, in the general population, we say the age at which your mother underwent menopause is likely the age at which you're going to undergo menopause. With HIV-infected women, that doesn't hold true. Also, you want to look for alcohol use, methadone or opiate use, and then certain medications like proton pump inhibitors, obviously steroids, a whole host of medications like anti-epileptic drugs can also cause secondary osteoporosis. Most commonly in men, it's going to be hypogonadism, alcoholism, and steroid exposure. In women, it's going to be premenstrual estrogen deficiency and steroid use. This is some of the workup for secondary causes, and this is not to say you got to do all of these things, but I think that what we need to do is, based on the history and the physical, determine which one of these we really need to do for our patient. I would recommend doing a vitamin 25 hydroxyvitamin level on everybody that you're suspecting osteoporosis, because we know that if your patient's vitamin D level is low and you give them bisphosphonates, there's a blunting effect to where they don't respond as well. They really need that vitamin D. And for these patients, we'd like for their levels to be at least 30, if not better. So the guidelines for general bone health, this is something we should be telling like pretty much everybody, is they should be on appropriate supplementation with calcium, vitamin D. Obviously, the best way to get these is nutritionally. But if they need supplements, we can supplement them. And also strength-building exercises. So they don't need to become a weightlifter all of a sudden, but they need to do some sort of resistance exercise or training. Smoking, for a variety of reasons, is implicated. Limit their alcohol intake. If you find any of these secondary causes, to be very aggressive about treating them as well. And then try to avoid medications or substitute medications that have been associated with bone loss. So bisphosphonates, we mentioned very briefly, this is your go-to first line for treatment of osteoporosis. And what these medications do is they bind to and inhibit the osteoclast. So the cells that are breaking down the bone, they inhibit them so that you can build up new bone. There are a host of bisphosphonates. Some are given weekly, some are given monthly, every couple of months, and then we even have one that you give yearly, which is kind of nice. The ones with these little stars by them, alendronate and zoledronic acid are the only medications that have actually been studied in the HIV-infected population, so we tend to use them more. Some of the side effects to look out for, especially with alendronate, are they can be very corrosive to the esophagus and can cause some esophageal irritation. So we ask for these patients to take it on an empty stomach with a full glass of water and sit upright for at least 30 minutes to minimize that. Very rarely there's been very adverse events like osteonecrosis of the jaw, but that also is a pretty rare side effect. And again, the optimal duration isn't really known. There are studies that suggest that these patients should be treated only short term, some that suggest that there's actually longer term efficacy, but there's really no consensus right now. We know definitely for a couple of years, 3 to 5 years, and then reassess. There is second line treatment. And the typical second-line treatment for women has been hormone replacement therapy, but the pendulum has really swung on hormone replacement therapy from, maybe the 90s, early 2000s, where they were being given away like candy, to now that we know that they actually increase the risk for certain types of cancers, like breast cancer and endometrial cancer, and the use is much more restrictive, rightfully so. Because estrogen is a bone-friendly type of medication, it used to be considered with patients with osteoporosis. The only thing that I could think of that might be an option now would be raloxifene, and this is only because it's very selective to the estrogen receptor. But really, when we get into the point where we're thinking of second-line treatment for osteoporosis, this is when we really need our endocrine colleague help. There's also intranasal calcitonin, which has very low rates of efficacy, and it's there, but it's not very effective, so we don't tend to use them. So one of the things that we also want to do is give realistic expectations to our patients. I was just in Philadelphia this weekend talking to somebody. We just happened to be talking about osteoporosis because that just comes up in general conversation. And she told me, well, I had osteoporosis. I was started on alendronate, and then my repeat DEXA was the same. So I thought, well, it's not really helping, and I stopped it. And that's actually successful treatment, because what we want is, yes, we would love to increase bone mineral density, but because time and age is working against us, not having no change in it, that it's not worsening, is actually a successful indicator that it's working. So I think we really need to set these expectations with our patients. Also, maintenance of height, so you're not losing more than 1 centimeter of height, is also something that is characteristic of successful treatment. And the fact that they don't have any other fractures or any signs or symptoms of fractures is also a marker that it's successful. So what about antiretroviral therapy? Because this is the question that we get all the time. Do we need to change their medications? So if somebody, and I'll just direct you to here, because all this we've already been through. So if somebody has not been on antiretroviral therapy before and they're treatment naive, then what we want to do is try to avoid tenofovir DF and PI-based regimens. So the best studied antiretroviral therapy that has a very positive bone profile is raltegravir, which is an integrase inhibitor. However, you have to take that twice a day, and really we're trying to improve adherence by limiting the pill burden. So there is a thought that this may not be specific to raltegravir, that this effect is likely a class effect for all integrase inhibitors. So gold standard is going to be raltegravir. Experts will tell you that you can probably use other integrase inhibitors. We just don't have the data showing that they work as well as raltegravir does. If they're already on treatment and if they're on tenofovir DF, then you can consider switching to abacavir or raltegravir or other integrase inhibitor. If they're on a PI-based regimen, you can switch them to a different regimen, usually an integrase inhibitor regimen. So the ones I really want to avoid are going to be tenofovir DF, PIs, are going to be the two big ones. For those that are on efavirenz-based regimens, you probably want to avoid efavirenz in these patients as well. So we do have some options, but I think that as more studies come out looking at other integrase inhibitors, where I think we may find that we can probably use the other ones too. So that's what we do for patients that are already on treatment. And then there are definitely cases where we're going to need help. We're going to need to refer these patients to an endocrinologist. And if you feel like their osteoporosis is unexpectedly severe for their age, for their comorbidities, for the kind of risk factors you would expect them to have that maybe they don't have, that's a clue to maybe send them to the endocrinologist. And also if there's significant secondary causes, particularly one that are endocrine related or are not easily reversible, that's another reason to refer them. There are patients that can have bisphosphonate failure, where they're on appropriate doses, yet they keep continuing to lose bone mineral density at alarming rates. So those are also patients that we want to think about referring to endocrine as well. And not all patients can actually tolerate the bisphosphonates to begin with. So if you've tried a couple, your patient's not tolerating them, that's another reason to think about referring as well. So my take-home point, so if you're asleep, this is the time to wake up. Take-home point is osteoporosis is common among our HIV-infected individuals. And though we don't really know the particular pathogenesis of this, we know that there's something about the HIV, something about antiretroviral therapy, and then also those traditional risk factors as well. And we need to be aggressively looking for this, because even now in our normal practice, we're not oriented to thinking about this. So, the FRAX is easy to do. It's a calculation. We don't always do that. So really to raise awareness that we need to be looking for osteoporosis, we need to be using the FRAX calculator, and to be aggressive about treating them when we find them. We should really have almost all patients that are on tenofovir also on calcium vitamin D. And I think there are some providers that are better at trying to transition patients in that direction. And pay attention to the type of medications that they're on. Because a lot of times, exposure to these medications over time may cause some of these comorbidities that the patients may not have been at risk for otherwise. And because this is very new and constantly evolving, look out for new guidelines. So in the next 1 to 3 to 5 years, I'm hoping there will be more consensus-driven guidelines to be able to help us out with this. Okay. So these are some of my references. The first 2 articles are excellent. So if you have some time to peruse them, or if you want to lock yourself in a closet or the bathroom for a couple of minutes to have some respite time, you could read those. And I'm happy to take any questions as well.
Question?
Mm-hmm.
So your general guideline is basically what they use for them.
Right.
And so with knowing that that they are going to have issues with the vitamin D, why don't you start them early? In the early days when we did HIV, we would have put everybody at their testosterone. Why not just go ahead and start them? Because you know that is part of it.
Right. I totally agree with you. One of the things that we're trying to do is have it be automatic, that as soon as somebody comes in, okay, we know that you're on these medications, you're at this age, let's go ahead and just start the calcium vitamin D. So I agree. I think that should be, and there was actually a study done at one of our international AIDS conferences, I would believe like 1 or 2 years ago, where they showed the benefit in having everybody on calcium vitamin D. Yeah. Any other questions? Mm-hmm.
I don't know if there's anyone on TV.
Anybody at our satellite sites with a question?
For several years, I took vitamin D once a week.
Yeah.
Now
Can't get any more.
I've got to go have that. They've been hassling me for years to get a phone tested.
You can go take my appointment. They already said it's for June something.
I know. It's just going to do it. Just getting there. If I get the appointment scheduled, I would go.